Good evening, everybody. Thank you very much for joining us here tonight for our virtual health seminar on kidney stones. Um, our presenter tonight is Dr. Francis Schanne, and Dr. Schanne is a board-certified urologist. He specializes in providing general urologic care with a focus on cancer patients and robotic surgery, and he also provides a full array of treatments for kidney stones, voiding dysfunction, enlarged prostate, and sexual dysfunction. And before I hand things over to our presenter, I just want to let everybody know that the meeting is being recorded. All of your microphones and cameras should be turned off, but please keep those off. And then I lastly just want to note that at the end of the session, we will have time for questions and answers. And so the way that you can submit your question is along the top of your Teams window. You should see a little icon there for Q&A. If you click that, it should open up a field and you can type in your questions there. So we look forward to that at the end. And with that, I will turn it over to Dr. Schanne.
Good evening, everyone. I'm Fran Schanne. I'm a urologist at Nazareth Hospital. I've been in the Philadelphia area pretty much my whole life, other than the 4 years I served in Fort Benning as a urologist. I did all of my education and training in the Philadelphia area, and of course, I live here now as well. So I'm going to be talking to you about kidney stones, and we'll talk about the metabolic component, sort of the medical aspect, that is, how do you make kidney stones and what might you be able to do to prevent kidney stones. And then we'll talk about how they're treated surgically. As a urologist, I am a surgeon, but I can also help people with medical issues, treating with medications and dietary recommendations. And I'm also going to talk to you about how kidney stones present. So kidney stones, most people think of as causing pain, which is understandable because kidney stones, if they start to move, can be extremely painful. And in fact, if you'll have the opportunity to talk to a female who has given birth and had a kidney stone, they will pretty consistently tell you that a kidney stone is more painful than giving birth. And so the hallmark of a kidney stone that's moving is pain, usually starting in the back, and it usually wraps around to the front, radiates down into the groin, which might be down into the testicle or tip of the penis in the male, or down to the labia. And that's because that pain is referred. There are nerves that pass by the ureter. That's the tube that goes from the kidney down to the bladder. And as the stone moves down through that narrow tube called the ureter, those nerves are affected regionally, so that the pain migrates. And so it seems to correlate somewhat with the location of the stone, but not completely. Starting with back pain that starts moving down around to the front and then down into the groin area. But not all stones are painful. If a stone is not moving, if it's not causing a blockage, or sometimes even if it is causing a blockage, but the blockage is not new, a stone can be silent. So it's not really safe to assume that your stone is gone. If you start to pass a stone and your pain goes away, don't make the mistake of assuming the stone is gone. It may not be gone. And so it's important to follow up and confirm that the stone has passed, because one way to lose kidney function is that if a stone that's causing a blockage without pain is not treated, that can actually ruin the kidney function on that one kidney on that side. The majority of kidney stones are calcium in nature, calcium-based kidney stones, and we'll go over some of the other causes of kidney stones as well. Most kidney stones are a combination of calcium and oxalate, and that's a salt. In fact, all stones are some type of salt. That's a cation and anion in combination. And so most of us know what calcium is, but oxalate might be less well known to you. Oxalate is an extremely common 2-carbon chain molecule that's the byproduct of every the energy cycle in every cell in the body. So oxalate's extremely common, and it binds with calcium very avidly. And so you have to get rid of all the oxalate you make, either in your stool or your urine. And when it gets into the urine, it likes to bind with calcium and make stones. And so a lot of calcium in your urine can be a bad thing. And so most folks, 75% of stone formers are going to be calcium oxalate stones. And so my most common recommendation for folks that make kidney stones is to follow a low oxalate diet. And that would be things like green leafy vegetables and colas. So a low oxalate diet and staying well hydrated are probably the two most important things we can recommend for people that are making kidney stones. When a patient presents with a kidney stone, again, usually there's pain, there's often blood in the urine, not usually blood that you can see. Your blood may just be dark colored or discolored, or you may have frequent urination. The frequent urination sometimes is because the stone has moved all the way down to the bottom of the ureter. The ureter is that tube that goes from the kidney to the bladder, and the last short segment of the ureter passes through the bladder wall. And so it narrows as it passes through that bladder wall because it's a tunnel. And so it's very common for kidney stones to get stuck there, even if they're quite small. And when it's stuck in that location, it will cause the bladder to get irritated and cause urinary frequency and urgency. So that might feel similar to a urinary tract infection if you've ever had a UTI. So frequency and urgency sometimes can be an indication of a stone that's very close to passing, or a stone that's stuck in the ureter. The best x-ray for looking at a kidney stone, and usually the x-ray that you'll get if you go to the ER for a kidney stone or flank pain, is a CT scan of the abdomen and pelvis with no contrast. Contrast is something usually given either to drink or by IV that helps highlight certain features in the body. It really shows up very brightly on CAT scan or other imaging studies. You don't need contrast for a CAT scan for kidney stones. It's a pretty straightforward CAT scan. It will give the most detail as to the size and location of your stones and whether or not there's a blockage. So CAT scan is the best study. An ultrasound can be helpful. The benefit of an ultrasound is it does not involve radiation. Insurance companies are more likely to approve an ultrasound than a CAT scan, but it doesn't give quite as much information as the CAT scan. An old study that's almost never done anymore is called an IVP, or intravenous pyelogram. That's rarely done anymore. Now, if you do have a kidney stone and it's starting to pass, you can take the size of your stone, like a typical stone might be 3 millimeters or 7 millimeters in size, subtract that number from 10. So 10 minus 7 is 3. That'll give you a rough idea how likely you are to pass that stone. A 7 millimeter stone has a 30% chance to pass, and a 2 millimeter stone has an 80% chance of passing once it starts moving down the ureter. This image on the left is a CAT scan, and this is a spinal vertebral body. So that's bone, bright white. And then over here is a stone in the ureter, very big stone, causing a blockage. That's also bright white. It's also a very dense stone. Stones will show up bright white on a CAT scan. This over here is a urogram where the contrast, I mentioned that IV contrast that can be injected in the vein, has been taken up and it's draining down the ureter, and it stops here because there's a blockage in the ureter right here. And this ureter is very dilated and it's very redundant, curving like a river that's been dammed. So that's called hydroureter, and that's a blockage in the ureter by a stone. So these are typical findings on imaging studies that are showing a kidney stone causing a blockage. Not only can that be painful, that can be somewhat emergent or very emergent, depending on the level of pain, because it can cause a lot of pain for the patient, but also can cause a compromise to their kidney function. And if there's infection above the blockage, that can make the patient critically ill. So sometimes it's a true emergency, and we really need to get some type of drainage into the kidney, either a stent or something called a nephrostomy tube. So this slide is talking about the differential of patients presenting with abdominal pain. There's lots of different things that can cause abdominal pain. And a kidney stone, usually the pain is pretty typical. That is, again, it's wrapping around to the front from the back and moving down into the right lower quadrant. And the patient kind of does a dance. They can't find a position that's comfortable at all. Whereas most of these other things that might cause abdominal pain, like appendicitis or infection or an incarcerated hernia, those patients won't want to move at all. They're going to present somewhat differently. And as I mentioned, the workup for a kidney stone usually is going to involve a CAT scan. KUB is a plain X-ray looking at the stone to see if it's visible or radio opaque, and I'll comment on that again in a little bit. And we look for urine culture to see if there's infection, and basic chemistries to look for kidney how good the kidney function is looking. And most patients presenting with their first stone or an emergent stone causing pain are going to show up in the ER. That's usually where they present. And we try to help them with their pain, give them IV hydration, and then see if they have a stone that needs emergent treatment. So as I mentioned, as a urologist, I'm also a surgeon. So a big part of my job is taking care of the surgical needs of patients with kidney stones. And that can be a lot of different things, like putting a stent in. I mentioned that sometimes the patients show up with an emergent or urgent problem where there might be a blockage causing a lot of pain or even infection that's making them quite sick or compromised kidney function. In those cases, we might just put a stent in, and that stent goes, it's a plastic tube that goes from the kidney down to the bladder, and it relieves the blockage. That's really the key thing. The stone itself would need to be treated at a later date, but just getting the kidney to drain properly is the most pressing issue. And so we put a plastic tube in there called a stent. Sometimes we can't place the stent, or it's possible the patient might be too sick to go to the OR for anesthesia. And sometimes we'll have a radiologist put a tube in the back called a nephrostomy tube. So that's a tube that goes into the back to drain the kidney. And again, that doesn't get rid of the stone. We'd have to figure out how we're going to treat that stone at a later date. In terms of how we treat the stones to get rid of them, there's shockwave lithotripsy, which is basically sending shockwave energy into the body targeted at the stone to break up the stone into fragments. And the hope there is that you'll be able to pass those fragments after the treatment is completed. For the most part, those stones need to be radio opaque, that is visible on a plain X-ray, to be targeted with shockwave lithotripsy. Ureteroscopy is an extremely common form of stone treatment. That's putting a telescope into the bladder and then an even smaller telescope into that little tube that goes from the kidney down to the bladder. Again, that tube is called the ureter, and that's usually where the stones get stuck because that tube is very narrow. So the telescopes that can fit into the ureter are very narrow, and they're called ureteroscopes. Most commonly, we use something that's more or less rigid that can travel up the ureter and allows us to put laser fibers into the ureter to break up the stone with laser energy, and then baskets to pull the pieces out. And then we put that stent in after the stone treatment. Again, that's that plastic tube that goes from the kidney to the bladder. So that technology works extremely well on a stone that's stuck in the ureter tube. For a stone that's up in the kidney, we can't use that rigid scope because it can't look around into all the rooms of the kidney. The inside of the kidney has a lot of different areas where the urine collects and drains. It's almost built like your hand. Think of your hand with the 5 fingers. The 5 fingers would represent little rooms coming off the renal pelvis. The palm of your hand would be the renal pelvis where the urine coalesces. But in those little finger-like projections that we call calyces, we have to be able to inspect into each one of those to see if there's any stones up in the kidney. That requires a flexible telescope that can bend and move from place to place like your finger can. And so we sort of poke that scope into different areas of the kidney, looking for all the stones that might be up there. And to be flexible like that, that telescope has to be even smaller than the telescope that can go into the ureter. So the ureteroscope that's flexible, the flexible ureteroscope, is super tiny so that it can accomplish its mission. But that also means we can only put the smallest of objects through there. And so the laser fibers and baskets that we use in the ureter with great success are going to be less likely to be successful up in the kidney, but still successful. We have to use a very small laser fiber. Generally, it means it takes more time to do the procedures up in the kidney. And sometimes it means that we can't treat the stone in one setting because we'll run out of visibility. As we laser the stone produces fragments of dust and small stone fragments that will have to pass. And eventually it's kind of like a snow globe. We get to where we can't see as well, and it becomes no longer safe to do the procedure. And so sometimes if we're doing flexible ureteroscopy up in the kidney on a very large stone, sometimes we'll have to stop, put a stent in, and come back at another time to do a second treatment for that large stone. Sometimes a stone is just too big for that treatment, and then we want to do this other option down here called percutaneous nephrolithotomy. And that involves the radiologist putting that tube in the back that I mentioned before. But this time, that tube is going to go through the back, down the ureter into your bladder. And then I use that tube to access your kidney through the back. And then I put a larger telescope than this flexible ureteroscope. In fact, a scope that's even larger than the one we put into your bladder. And through that, I can put a device in there that will not only break up large stones, but also suction the pieces out. And then hopefully in one trip to the OR, we can get rid of all the stone that's in the kidney, unless it's an extremely complicated stone. And then we put a stent in down the kidney into the bladder, and then we close up that track. And the patient usually goes home the next day after that procedure, whereas ureteroscopy, shockwave, and stent, those can be done as outpatient procedures. Once in a while, there's a need for laparoscopy to treat a kidney stone. So I do a lot of robotic surgery. And if I have a very complicated stone or in special circumstances where there's a second problem along with the stone, sometimes I'll use robotic technology to take stones out. This is a slide talking about the types of stones again. This slide has a lot of medical literature or a lot of medical commentary on it, so I'll just try to hit the highlights so as not to put the whole crowd to sleep. But as I mentioned, calcium-based stones are the most common stones. In fact, as I mentioned, 75% of stones are calcium and oxalate stones. And there's lots of different causes for calcium stones, and it can be actually quite hard to know why any one patient is making a stone because there's so many different pathways. There are some specific causes of kidney stones that can be very helpful to know about. Probably the most notable is a patient with hyperparathyroid, which is pretty rare, but that's the one treatment for kidney stones where you can do a surgery and stop the production of stones by removing the adenomas in the parathyroid. The parathyroid has a big role in calcium metabolism and the management of calcium in the blood. And so if you have an adenoma in the parathyroid that's producing too much parathyroid hormone, you'll have very high levels of calcium that'll lead to very high levels of calcium in the urine and calcium stones. But again, that's pretty rare. There are some patients that will come in with calcium oxalate stones that have different metabolic causes that are hard to narrow down, but sometimes what we'll do is put them through a metabolic testing. The one we use in our office here is called Litholink, where we study a 24-hour urine collection and try to see if maybe the cause of making so many calcium-based stones is not enough citrate in the urine or too much calcium in the urine or perhaps too much sodium. Those can be things that will cause people to have high rate of calcium stones. Another cause of stones, usually not calcium oxalate stones, is infection. If you have recurrent infections in the urine, it can affect the pH, particularly bacteria such as Pseudomonas or Proteus. They will tend to lower the pH of the urine due to a mechanism called by urea splitting. It produces a lot of ammonium, and then that can lead to stone formation. Uric acid stones represent about 5% of kidney stones. These are very interesting. These will not show up on a CAT scan, at least not early on. They're not radio opaque. They don't show up on a CAT scan. They're not visible on a plain excuse me. They don't show up on a plain X-ray. They do show up on a CAT scan. They're not radio opaque on a plain X-ray. But if they're around long enough, eventually they'll get calcified because everybody has calcium and oxalate in their urine. If the uric acid stones sit there for a while, they will get calcified, and that can make it more difficult to understand how they're made and how you can treat them. But if you have pure uric acid stones, this is one stone that you can actually dissolve with medication. And patients ask that question all the time. Can you dissolve my stones? Well, it's only true if you have pure uric acid stones. And again, that's a minority of cases, but you can take something called potassium citrate, and that will alkalize your urine. So unlike the infection stones in patients where uric acid stones are the problem, we want to alkalize the urine with potassium citrate. The citrate actually is a stone inhibitor, and it will also lower the urine. And if you take that frequently throughout the course of the day, usually it takes either 3 or 4 doses a day. So it's not that easy a medication to take. It's not just once a day. You have to really get the urine pH to change. This can actually dissolve a stone that's already been made. That's the only case where that's really true or possible. What's true for what's true for all stone formers is that increasing fluids is really helpful. What I like to tell patients about that is to think about a powdered lemonade. You know, if you have a glass of water and you want to make lemonade and you put powder into the glass and you see the powder at the bottom of the glass and you stir it up and the powder does not dissolve, it's because there's too much powder to dissolve in that amount of water. And stones are kind of like that. If you're making more urine because you're drinking more fluid, you're going to dissolve those salt crystals and be less likely to make stones. So staying well hydrated is a key way of preventing stones, no matter how you make stones. Um, and so that's super important. And um, of course, if you're actively passing a stone, we want to help you with pain medications. And if you're actively passing a stone, we usually like to see you strain your urine. If you don't have a strainer, or if we forgot to give you a strainer in the office, or the ER didn't give you a strainer and you want to strain your urine, one inexpensive and easy way to do that is use a coffee filter. And if you pass a stone into your toilet, it's usually worth grabbing that stone, even though that sounds kind of yucky. Grab that stone out of your toilet and bring it to our office for analysis. That stone analysis can be really important for figuring out how you make stones. Okay, so this slide is starting to talk about the surgical treatments, which I'll start to go over in a little bit more detail now. This is showing stones up in the kidney. This is in the renal pelvis. I mentioned how the collecting system inside the kidney is kind of shaped like your hand. The renal pelvis might be like the palm, and going down into the ureter, the UPJ, is kind of like your wrist. And then these are the finger-like projections that are calyces inside the kidney, where you might see stones forming up in there. And this kind of shows a telescope that can go up into the bladder and into the ureter to perform ureteroscopy. This is a picture of a stone in a basket being zapped by a laser through the ureteroscope. Shockwave lithotripsy, that's the one that's going to use external energy from there's lots of different ways to deliver that energy, but basically you're delivering an energy wave through the body to break up the stone. And this is a technology developed by a company in Germany and brought to the US in 1984. And the original unit by Dornier was so enormous it required an entire room in the hospital or operating room to fit. This is a slide showing that unit, the HM3. This is what was available in 1983. You basically have to put the patient on a gurney or lift, and then put them down into this bath, and then the ultrasound energy had to travel to water to break up the stone. So completely cumbersome and expensive to install, and it wasn't available in many locations. Initially, in the Philadelphia area in the late 80s and 90s, it was available at Penn, and then there was a site in New Jersey, and then at Jefferson. And then eventually this technology got smaller. This HM3 from Dornier was very powerful, so it was very effective. There's a picture of the bath again. But it was not portable, obviously. The units now are still quite large, so not too many places have a permanent unit in their hospital. For the most part, if you're going to have lithotripsy, the unit is going to be brought from the outside. So that makes it logistically a little challenging because you may not be able to access it on the time that works for you. And so it can be hard to schedule this treatment, and it requires basically just sending energy at the stone to break it up, and then you have to pass the pieces. There's also a 1% risk that it could cause a significant bleeding into the kidney. There's just 6% chance that pieces of the stone will get stuck on the way out. But some studies suggest that the success rate is pretty high for stones, even of a significant size, although most urologists are moving more away from S-wall in favor of ureteroscopy, and I'm in that camp as well. I'm much more likely to recommend ureteroscopy for stones. I like being able to see the stone and be certain that the shock wave was, the energy that I used to fragment the stone was successful. It's not going to cause, ureteroscopy is not going to cause that bleeding in the kidney that is a risk with shockwave lithotripsy, because it's not delivering that energy level through the body. It's a more focused energy treatment, but it's still possible, especially if we're treating stones up in the kidney, that you could have fragments that are stuck on the way out. Ureteroscopy, again, as we talked about before, taking a telescope, traveling up the ureter or all the way up to the kidney to deliver a laser fiber to break up the stone. And if possible, we'll use a basket to pull the stones out. But a lot of times when we use ureteroscopy for stones in the kidney, the biggest risk is causing a ureteral injury as you try to pull stone fragments out with a basket. So I won't be overly aggressive in trying to pull stone fragments out. I would favor allowing them to pass on their own, which means of course, there's a risk that one of the fragments could get stuck on the way out, and you could need a second treatment for an obstructing stone fragment. Usually when I leave a stent in after ureteroscopy, if I'm pleased that we're done treating that stone, that stent will go from the kidney down to the bladder, and there'll be a string attached to that stent, and we'll tape that string to the lower abdomen or the penis, and you'll come to the office a week later to have that stent removed. So that's a week with a stent after ureteroscopy. This is just some information about the evolution of ureteroscopes. Continue to be improvement with ureteroscopic technology, including now disposable ureteroscopes, single-use flexible ureteroscopes. This is a flexible ureteroscope. That's the mechanism that would travel all the way up into your kidney. This is the end that I hold on to, and this plugs into a camera system that shows me the image on a television screen, and this is what brings light through this light cord that then travels all the way up there. PCNL, this is for treating really big stones. If you have a stone that's starting to fill the renal pelvis, that's going to be very hard to treat with ureteroscopy, or if it's very dense, that could be really hard to treat with ureteroscopy because the laser fibers are so small. So sometimes we recommend going through the back. That requires putting a tube into the back in radiology. That tube's called a percutaneous nephrostomy tube or nephroureteral tube, because I would want the tube to go through the kidney, down the ureter, into the bladder. So that's what the radiologist will do for me. That's interventional radiology at Nazareth. That's Dr. Feldstein. He's fantastic. He does a great job, and he'll put that tube in typically on a Wednesday, and I'll typically do the kidney procedure on a Thursday. You would go home after he puts the tube in, and typically after I do my procedure, you would stay one night in the hospital, although sometimes patients will go home the same day. The tube he puts in is relatively small, and then I have to dilate that track to put a sheath or a device that will hold the track open so I can get into your kidney. And that that device can be 26 French or bigger, which is basically about the size of your index finger or thumb. And through that, I put a telescope that's large enough to pass a device that will break up the stone with some pneumatic energy and some ultrasound energy. And then it's also large enough to have suction, so we can suction the pieces out of the stone. And that's how we can treat really big stones up in the kidney without having to make an incision or anything of that nature. So that's percutaneous nephrolithotomy. Sometimes if the stone is really complicated and it's in many areas of the kidney, we won't be able to treat that stone all in one setting. So we might separate the treatment into 2 different days. That's pretty unusual for that to happen. But regardless, when I'm done, I'll leave some type of tube in, usually a stent that goes from the kidney down the ureter into the bladder, just like your ureteroscopy, except in this case, that stent won't have a string on it. So a week or 2 later, I have to put a telescope in the bladder to remove this stent. That's percutaneous nephrolithotomy. And then lastly, if you have really big stones in the kidney, or special concerns like a secondary problem, like a blockage. If you remember that picture I showed you where the collecting system in the kidney kind of looks like a hand and the wrist was an area called the UPJ. Some patients are born with a narrowing at that UPJ, so the renal pelvis is super dilated and they require reconstruction of that area. And that's best done with a surgical robot. I do a lot of robotic surgery, which is basically laparoscopy. Here are laparoscopic ports in place in the abdomen. These are specially designed to work with the robot. And we put a camera in one port and instruments that I control as hands in other ports. Sometimes we'll put another port down in this location. And using robotics and laparoscopy, I can take out really big stones. Here are some enormous stones that I'm pulling out of a patient's kidney. And in that same procedure, I'm going to fix their blockage at the ureteropelvic junction. That surgery is called a pyeloplasty. So the surgery is robotic pyeloplasty and removal of the stones. It's called pyelolithotomy. So that's a nice use for the robot. It doesn't come up too often, but for the patients that have that combination of problems, it's very helpful.
Thank you so much, Dr. Cheney. That was a great presentation. And so now we are moving on to our Q&A session. We do have a few questions in the chat that I will get to, but while we're going through those, again, there's the button along the top of your window where you can click to access the Q&A. Please, if any questions have come up, type those in there. So, Dr. Cheney, the first question that we received, how do I prevent kidney stones?
So the number one consistent messaging for that is drink lots of water, staying well hydrated, make your urine look like water. That's true for all stone formers. Beyond that, it's not the same message for all patients. Now, 75% of kidney stones are made of calcium and oxalate, so it's a good bet that a low oxalate diet will help prevent kidney stones for you, but that's not always the case. So it's helpful to know what are your stones made of? And if you're a frequent stone former, it's also helpful to do that 24-hour urine collection that I mentioned. We use a product called LithoLink. That helps us understand what's going on in your blood system that might put you at risk for stones. You might be somebody that has a bit too much sodium in your diet, and that can lead to things like low citrate in the urine and uh, increased oxalate in the urine and increased urinary calcium. So in those patients, we might suggest a low sodium diet. Similarly, patients that have a high protein diet tend to have low citrate and high oxalate levels. And of course, we mentioned during the talk other causes that are less likely, but you could have recurrent urinary tract infections, you could have cystine stones, you could have hyperparathyroid, or you could have uric acid stones. So it's important to figure out what the stones are made of and then possibly also do a metabolic evaluation.
Next question is, can I dissolve my kidney stones with medications?
So the only stones that really can be dissolved once they're formed are those uric acid stones. So uric acid stones, if they're around long enough, will get calcified and then they won't be able to get dissolved. But if you have a pure uric acid stone, it is possible if you're really good about taking your alkalizing medication called potassium citrate. If you really stick to it and take it 3 to 4 times a day, you might dissolve that stone. Now, if you have stones and you have a history of uric acid stones, you could do a CAT scan. And if the CAT scan shows stones and then you do a plain x-ray and it doesn't show those stones, then it's a good bet that what you're looking at are uric acid stones and you might be able to dissolve them. Or if you have a history of uric acid stones, you probably ought to be on potassium citrate on a daily basis.
Next question, do all kidney stones need to be treated?
That's a good question because you can just observe kidney stones. There are some patients in whom the stones don't change in size or number. They're not making new stones, and we just keep an eye on them, especially if they haven't had a stone event. So a patient that's never passed a stone is going to be a lot less impressed that they need to have something done versus somebody that's been through a painful stone episode. So if the stones aren't increasing in number or size, I can't really compel that patient to seek treatment, although I might give them that advice. And then there are patients who have stones that are stable in size and number, but they're not great surgical candidates. They're not somebody that I want to put through the risk of anesthesia and surgery. So certainly in those patients, if the stones aren't causing a blockage, we'll just keep an eye on them.
Or is it painful to pass a kidney stone?
Yes, it hurts a great deal for most patients to pass a kidney stone. Sometimes that's not the case, but usually when I have the opportunity to talk to women that have had pregnancy and kidney stones, they'll say that it's more painful to pass a kidney stone than to deliver a child. So that's got to hurt, right? So that's a pretty painful thing to go through. But there are situations where a patient might be passing a stone with little to no pain. So it's not always reliable to count on that pain as an indication of whether the stone is still there. You could have a stone that has stopped moving and the pain has gone away. It doesn't necessarily mean that the pain has that the stone is gone. So it is important to follow up.
And lastly, do pregnant women get kidney stones?
Pregnant women are actually more likely to get kidney stones, and that's for a whole host of reasons. And some of those are hormonal, metabolic, and mechanical compression. The pregnancy will cause a relative blockage to the ureter, so the urine doesn't drain as quickly, so there can be relative stasis of urine, and the crystals can fall out of solution and form a stone. But of course, there's special considerations for surgeries and interventions for pregnant women. So we have to tailor our treatment for the stage of pregnancy, the size of the stone, and if we wind up putting a stent in on a patient who's pregnant, they may need to keep that stent all the way through the end of pregnancy. So that can be a delicate situation, but pregnancy actually increases the risk of kidney stones.
All right, thank you again, Dr. Schanne. Those are all the questions that came in. And so for those in attendance, thank you once again for joining us. And here is Dr. Schanne's contact information if you're interested in reaching out to schedule an appointment.